My name is John Morris. Just as a reminder, please put your device on vibrate or turn it off. And thank you all for coming to the 2017 State of the Knight ADRC address. Just for CME purposes, I will indicate my disclosures. As many of you have heard, the vast majority of the funding that supports the Knight ADRC comes from the National Institute on Aging, but we're very pleased to have support from the Alzheimer Association, as well as foundations and donors. So the Knight ADRC in 2017 continues to be a very strong and very prominent research program. I think there are several factors that contribute to these strengths. As we'll be discussing at some length, we have remarkably dedicated participants, and these participants now span the adult age range. The youngest individuals who we see as research volunteers are 18, and currently the eldest is 101. As I think everyone knows, we ask a lot of our participants, but they provide us with a very rich database, not only in terms of clinical and cognitive information, but imaging and biofluid and genetic information as well. We have been fortunate, I think, to have stable leadership. I've been around in a leadership position for 2 decades, but of course I'm only able to do that with the support of all of the rest of the leaders here at the Knight ADRC, including our 2 executive directors, Virginia Buckles and Krista Mulder, and I thank Krista for helping to put together this presentation today, but the leaders of our many cores, or many research projects, the Memory and Aging Project, where our research volunteers are assessed, and our faculty outpractice, the Memory Diagnostic Center. Another strength is the quality and breadth of our science. It's primarily translational, but we think that much of it is pioneering, and as a group, we are very productive. And of course, it's difficult to argue with our overall guiding mission, that is, we would like not to be a Knight Alzheimer's Disease Research Center very much longer, because we'd like ultimately to prevent the onset of Alzheimer's disease symptomatology. But in 2017, we also have some threats. I'll discuss one of them in more detail. That's the burden we've been placing on our highly dedicated participants in terms of the research studies in which they participate. Excuse me. And then something yet to play out. We don't understand the current ramifications of what the NIH is attempting to do in order to allow more mid-level and early stage investigators be more successful at getting research dollars from the NIH. One strategy that is certain to be implemented in one form or another is to cap the number of awards that any single investigator is allowed to serve as a principal investigator. An early proposal would be that a program project grant would equate to something like 11 points, and originally a center grant like the ADRC would be 11 points. I'm the director of the ADRC and 2 program project grants, so totaling that up, I have 33 points, and they're suggesting, at least originally, that any one person can only have 21 points. So we'll have to see what the implications of the final implementation of this system may be. And then not listed here, but one that we've been dealing with for over a decade, is the uncertainty always about what Congress and the administration will allow for funding appropriations for the NIH. That uncertainty can be very difficult to deal with. We have added some new personnel listed here. The people in brackets are two individuals who will begin with us next month, but we're really emphasizing, as I will mention, our nurse clinicians. As a matter of fact, Nicole Elmore is a nurse practitioner, but many other new additions to our staff, very positive additions. And of course, we've lost some individuals to other opportunities within the past year. So I think most, if not all of you, are aware of this, that our Memory and Aging Project was officially established in 1979. So we're coming up in 2 years on our 40th anniversary of the first research volunteer enrolled in the Memory and Aging Project. Our volunteers consider themselves affiliated with the Memory and Aging Project. That's where they come. That's where they're assessed. They don't know, or very few know, that their participation is funded by one of 4 large grants listed here: the actual ADRC grant, the 2 program projects that I mentioned earlier, HASD, and more recently the Adult Children Study, and an international cooperative study, the Dominantly Inherited Alzheimer Network. So the first funded program project that continues on is the Healthy Aging and Senile Dementia Program project. It was initiated 1984, and the following year the ADRC grant was initiated and it was endowed by Charles F. and Joanne Knight in 2010. All of these grants to date have been continuously renewed, not always without some angst and some struggles, but we've been very fortunate that we have had continuous funding. So the grants are awarded in general for 5 years, at the end of which we must put in a renewal application which gets peer reviewed and hopefully given a fundable score. The Adult Children Study is the one that most recently was renewed beginning last fall. But here you can see that with these 4 grants, we are almost always in grant writing mode. For example, HASD, the program project, will end in April. This current budget cycle will end in 2009 in April, which means in order to have uninterrupted funding, we must submit the renewal application in January of 2018 so that it is reviewed in time and hopefully approved so that funding can continue once we reach May of 2019. But right after we submit this renewal application, and preparations have already begun, so we're now some 2 years in advance of when we hope we get the renewal funding. As soon as we finish the renewal application to submit to the NIA in January of next year, we have to pay attention to the Diane renewal, which should go in next November. The following year, the ADRC grant itself has to go in, and the following year, the Adult Children Study renewal application. So continual grant writing. And these are non-trivial grants. They're 1,000 pages or so in length. Okay, so leadership. My future plans, I've announced this already, is for the foreseeable future to continue as the principal investigator for both the program projects. They are linked program projects, and I will continue on as the principal investigator. I will likely continue to be the director for the Knight ADRC in its next renewal, but we have a planned transition to the next leader, and I think here you can see that already I am meeting with this next leader to go over some of the complexities of how we do our clinical assessments. So here is my grandson, and we're going over how you rate the CDR and how it rates. He has very good questions about mild cognitive impairment, but he's eager to learn, and so he'll be eventually ready to take over. Randy Bateman began in July 2015, transitioned my directorship of Diane to Randy, and so he'll lead the renewal application in coming up. At this point, I would like to begin to identify and prepare faculty to eventually take over not only for the grants that I direct, but the critical component of each grant, which is the clinical core for each of those 4 large grants. Right now, I'm the clinical core leader for all 4 of them, and so we really need to bring in some succession planning for the clinical features and programs of all of these grants. Of course, I do a very minimal job as core leader. We have many people who provide the leadership. I will mention Angela Oliver and Maria Carroll in the Memory and Aging Project. And just the past year, Joey Snyder has taken over from me as the director of our faculty outpatient practice, the Memory Diagnostic Center. So what binds us together? Again, this is not new, but we're interested in identifying Alzheimer's disease prior to symptoms. Preclinical Alzheimer's disease. And this has come around because of a revolution in the past 15 years that we have markers of the brain pathology of Alzheimer's disease such that we can identify the illness in living people prior to the onset of any memory symptoms. And these biomarkers include brain imaging, including amyloid PET for the proteins amyloid and tau, and evaluations of the concentrations of those same proteins in the cerebral spinal fluid. The questions are, if someone has an indication of preclinical Alzheimer's, they have abnormal biomarkers indicating brain pathology, does that mean that they all will eventually develop the symptoms of Alzheimer's disease? If they continue to live, will they all develop dementia? Can we identify that change from when they become symptomatic, when they change from being cognitively normal to symptomatic? This is very important, and our center as a whole has been very invested in trying to identify these answers to these questions, because we're quite interested in intervening in these normal individuals prior to the onset of symptoms in a hope to delay the onset of symptoms or perhaps even prevent the onset of symptoms. So we're looking at prevention trials of disease-modifying drugs. And this is based upon work done by the Diane group as a whole, when we are estimating when symptoms might occur. We are looking how many years prior to symptoms we think the biomarker changes may occur. Our clinical instrument is the clinical dementia rating, and it really only barely starts to show some change a few years, 5 or less, before symptoms are fully manifested. Now we have markers of brain metabolism, including FDG-PET, and performance on objective measures of memory and other cognitive domains, and they may start to begin perhaps a decade before we recognize that symptomatic Alzheimer's disease is established. Then we have these other biomarkers, including how much certain regions of the brain atrophy, particularly the hippocampus, measures of tau, concentrations of tau in the cerebral spinal fluid, and amyloid imaging is marked here by PIB imaging, and this may begin 15 years before symptoms. But the most critical understanding of when the disease process begins in the brain continues to be, at least in our hands, the change in the concentration of amyloid beta in the cerebral spinal fluid, and this may be 20 to 25 years before symptoms are expected to occur. So this indicates several things. There is this long preclinical period in which we can time interventions to hopefully delay or prevent the onset of symptoms. And second, it underscores the value of a combined approach, a multimodal approach, clinical, cognitive, imaging, CSF, but really underscores the value of measuring the cerebral spinal fluid because it's the first indicator that something is going on. Now, many years ago, we didn't have biomarkers, and so we only were able to infer the presence of preclinical Alzheimer's disease by looking at brains of individuals after they died. This is work done by Joel Price and myself many years ago. And here is looking at the presence of neurofibrillary tangles in cognitively normal people at age 60, 75, and 88. And you can see that in medial temporal lobe structures, there is an accumulation of neurofibrillary tangles that seems to be age-dependent, increases with age. This was well known to many of us in the 1990s, including the work of the Brocks, Heiko and Eva Brock. But now it has new emphasis. It seems like it's a new entity. It's called primary age-related tauopathy. I don't think it's new, but it does have a new name. But all of us probably accumulate tangles in as cognitively normal. What we think changes us from being, that puts us on the road to being symptomatic, is the presence of amyloid plaques, shown here. And these are brains of coronal sections of temporal lobe in individuals from 80 to 74. And you can see some people appear to have virtually no plaques in the neocortex. Others who are cognitively normal have some diffuse plaques, but in patches. There still are much of the neocortex that is unaffected by plaques. But then it can become more continuous, and this would be someone who we think, even though they're cognitively normal, has full-blown preclinical Alzheimer's disease. So already mentioned, we have both imaging and fluid biomarkers. We can assess individuals during life. We no longer have to wait to look at post-mortem sections. We can evaluate the distribution and the quantity of these abnormal lesions in living people. And this has been very important for the idea that perhaps all of the therapeutic failures that we've had of what we thought were disease-modifying drugs over the last 15 or so years may be coming to a close, we hope. We think now we can intervene with these medications during this preclinical stage, since now we can identify it reliably, and we're trying to do, as we mentioned, these prevention trials. There are two groups of individuals who have been leading the preclinical treatment, clinical trials. First are cognitively normal individuals who are at high risk for developing Alzheimer's disease because they inherited a causative mutation. That's the Diane Trials Unit, which launched in 2012. Followed the next year by the Alzheimer Prevention Initiative in individuals who have in a family with a known presenilin mutation in Colombia, South America. And then the Tomorrow trial, which doesn't look at a causative mutation, but a very high risk of developing due to genetic variants. So these are all trials that have begun in the past 5 years in hopes of preventing Alzheimer's dementia. And then we've looked also at why the trials of what we thought were reasonable drugs to help people with symptomatic Alzheimer's disease. Maybe we can re-examine the study designs of those trials and look at higher doses, and to ensure that the research cohort, the people entered into the trial, truly have the Alzheimer pathology that we are targeting. And so we've begun here at Washington University, I'll mention this in just a moment, 2 trials of different agents that look at people who are not asymptomatic, but very mildly symptomatic, the very earliest stages. So we have these trials that are ongoing. One is the A4 study that Randy Bateman is the Washington University site leader, that takes cognitively normal individuals and gives them an antibody, solanezumab, directed towards aggregated soluble A beta, and hopefully will delay or prevent the onset of symptomatic Alzheimer's disease. And we've met our enrollment criterion and continue to follow these individuals in the Memory and Aging Project. The early study is going to be looking at also cognitively normal people. But in this case, they won't get an antibody infusion. They'll get an oral agent, a BACE inhibitor that inhibits an enzyme that releases amyloid beta from its precursor protein. We haven't initiated this study as of yet, but we'll hope to do so very soon. Then the next 2 studies are of people who are very mildly symptomatic. One is another BACE inhibitor, and we hope to have 12 individuals enrolled and randomized to drug. We're about halfway there. And then another antibody directed towards amyloid beta that is led by Joy Snyder, that has had a lot of interest because its phase 2 studies seem to show not only did it reduce the amount of amyloid in the brain, it slowed the rate of cognitive deterioration. And then Joy Snyder also is talking with the pharmaceutical firm AbbVie about another antibody, but this time directed towards tau. Now, both the first antibody, solanezumab, directed towards amyloid beta, and the anti-tau antibody began in the laboratory of David Holtzman. So these are another way the Knight ADRC and the faculty associated with the ADRC are contributing to the fight against Alzheimer's disease and trying to find effective therapies. So something about our volunteers in the Memory and Aging Project. We follow 854. About 475 are 65 and older. They're enrolled in under 2 grants. The program Project Healthy Aging and Senile Dementia, or the ADRC, and they're followed identically. The Adult Children Study, both HASD and ADRC enrolls primarily cognitively normal people, but also people with symptomatic Alzheimer's disease. We have a little less than 275 individuals who are in the Adult Children's Study. All of these at entry are cognitively normal, and they're age 45 and up. And then the Diane study at Washington University enrolls individuals 18 and up if they come from a family in which there's a known pathogenic mutation that causes Alzheimer's disease. Now, we enroll both people who end up having inherited that pathogenic mutation, as well as people who did not inherit it, but about of the asymptomatic people, it's about 50-50. And the Washington University site in Diane, which is now a 15-site international project that has not only the United States, Australia, United Kingdom, Germany, Argentina, Japan, and Korea as performance sites. About 20% of all Diane participants were enrolled here and followed here at Washington University. So our age range, as I mentioned, is 18, of all these individuals, 854 individuals, 18 to 101. 57% are women, 16% are African American, and some of these people, as I keep mentioning, are extremely dedicated. They've been in the project for almost 3 decades. And they come from all over, at least all over the United States. Here are the older individuals, 65 and older. You can see that 344 are cognitively normal, and 132 have early symptomatic Alzheimer's disease. and of these older individuals, about 18 to 19% total are African American. Now, to come into the Memory and Aging Project for ACS, you have to be 45 and older and cognitively normal. If you're 65 and older, you can be either cognitively normal or early symptomatic Alzheimer's disease. Have to speak English. I'll just make an aside. Randy, I think, is just back from Hong Kong. I don't know where Dave is just back from. Many of you go to other countries, and it's amazing to me that our hosts and the conference attendees at these international sites always are able to converse in English. If they come here to present, they converse in English. It's remarkable because, I think in English, what do we call a person who speaks 3 languages? Trilingual? Yes? Person who speaks 2 languages, bilingual. Person who speaks 1 language is American. And we expect them to speak English, and they do. It's remarkable. But I can't speak anything but English, so our enrollees have to be English speaking, have to have a study partner or a collateral source, have to be generally stable. It's not the case. Some people think that our individuals who are volunteers are all in the prime of health. They can have multiple illnesses, but they must be stable to allow them to participate. And they must be willing to undergo all of our studies. So I mentioned participant burden. Here are just some of the data that make us concerned. So not everyone who is eligible to come in for their annual clinical assessment necessarily does so, but most do, and they make an appointment to come into the Memory and Aging Project for their assessment. And of course, the Memory and Aging Project staff arranges to have a clinician there and a nurse there and ultimately a psychometrician there. And we're seeing an increase in the number of people who cancel that appointment, sometimes the day of the appointment. So we lose the opportunity to see people, and it disrupts our schedule. But more alarming is why, because this cancellation rate seems to be increasing. Now, this primarily is in our 65 and older individuals. About half of the cancellations we think, and this is thanks to Angela Oliver, we think are unavoidable. Suddenly people become ill. In January, we have people who can't venture out in the snow, or they have other pressing needs, such as a death of a relative. But about half probably are avoidable. And written there is the primary potentially avoidable is scheduling conflict. I think that's what people tell us when they don't want to come in. I've got another scheduling conflict, that's why I'm not coming, but they don't prioritize their Memory and Aging Project participant. So, and again, for our older group, 65 and older, here's our participation rate in our biomarker studies. And our goal is to have 80% completion, not only at the baseline, but every 3 years when they come in for follow-up. We make an exception for lumbar puncture. We say goal will be 70% or better. So here you can see what's happened to our amyloid imaging from 2015, 2016, 2017. It was very low in 2015. It wasn't just participant burden, there were other factors. And it's steadily increasing, but still below the goal of 80%. Cerebral spinal fluid is around 55 to 65%. We want it to be at least 70%. MRI is better, but barely meets our goal of 80%. And blood draw is not a problem. So we are following very carefully individuals who are eligible to come back for their follow-up biomarker assessment. Get about 2/3 of people to come back for their amyloid imaging, but only about half for their lumbar puncture. We presented these data, the cancellation rates, the low participation rates, to our external advisory committee for the 2 program projects, HASD and ACS, just last week. The advisors said that these program projects are unique and extremely important for the research field because our individuals are so well characterized and have such rich biomarker data. But they're concerned that we're not paying attention to the goose that lays a golden egg, because many investigators would understandably like to avail themselves of this remarkable cohort of individuals already so well characterized. But by doing so, by having these affiliated studies participate and ask additional assessments of our participants, it may be, according to our advisors, undercutting our program project goals so that our goose is cooked. We don't want to keep making our participants available for other studies. We want to do that. We want to support other studies, but not at the cost of them not coming back and completing their memory and aging project assessments. So the advisors are concerned about our chances in just a few months when we submit HASD renewal. We're a biomarker study, and some of our biomarker follow-up rates are 50% or less, so we could be at real jeopardy. And so they've given us some guidance about how we can prioritize referral of our participants for other studies to reduce burden, not keep asking our participants to do another study, but also some of these studies potentially could introduce bias. There's a cognitive study that maybe affects our memory and aging project psychometric assessment, and so they want us to be very careful going forward in our authorization of a request to access our participants. We're doing other things. We have a very rich clinical and cognitive assessment. It's also very time intensive for our clinicians to generate the data, and as a result, our cohorts are relatively small. We're trying to increase our capacity to see more individuals, spread out the burden. And one way we're going to do this is start with a nurse practitioner who will come next month, Nicole Elmore I've mentioned already, to train in our assessments, and then eventually, when qualified, take on a major role in providing clinical assessments. Some of us have tried to see 2 assessments in a single assessment slot, and that has been more or less successful. And we're working hard to make sure that all available slots are completed, that we don't waste it with individuals who cancel at the last moment. And we're improving and increasing our nurse clinician corps as well. Georgia Stobbs-Kuki is already here and acclimating to the Memory and Aging Project, and Becky Cusinelli will join us next month as well. So what about these other studies, affiliated studies? They're all scientifically terrific. They address very important concerns. They range from undergoing a driving evaluation on the road or having a device placed in their car to monitor their driving, to looking at tau metabolism, to looking again at cognitive performance, prospective memory. Our participants, when we call to ask them to participate in these studies, indicate that perhaps they're getting overwhelmed. What study is this? It seems like you've been contacting me a lot as late. I've already signed up for a lot of studies. Boy, there's a lot of research going on now. Just in 2016, here are some of the requests that just the program project HASD has received for access to our participants. And we've agreed, I don't expect you to read it, it's just a lot of studies. And at the bottom, we're beginning a collaborative study with Betsa Zlakovic and Arthur Toga at University of Southern California that will add another imaging sequence to our individuals with a contrast agent, a dye. And so we already are asking a great deal. We're going to be evaluating how our participants see our request for their participation. Dr. Susan Stark from the Program in Occupational Therapy was successful in getting a grant from the National Alzheimer Coordinating Center to do a comprehensive survey of the burden to participating in Alzheimer research and what might incentivize people to participate in research. This will be with University of Pittsburgh Alzheimer Center and the University of Wisconsin Alzheimer Center. Sarah Hartz and Jessica Mozerski from the Department of Psychiatry here been awarded a pilot study to see how we might begin to return individual research results to our participants. This is a pilot study. We don't know that it will lead to other biomarkers being returned, but we want to see how it goes. We'll start with CDR0 individuals who have had a research brain MRI within the past year, and we'll see if people want to know it at the time they come in for their clinical assessment. If they do, then Sarah and Jessica will give them their images at the end of their psychometric assessment, and then follow up with them to see whether this was a valuable experience or not. Some of you know that John Gublar from the Department of Brain and Psychological Sciences worked with Matt Gobble from the Department of Political Science and myself and others to survey about 200 of our participants several years ago in a hypothetical way. Would they want to know the results of not only their MRI, but their CSF levels of A beta and tau and their amyloid and tau imaging? We were careful to indicate that knowing your research results may not be informative, because we can't say that if you have a positive amyloid PET scan that you will become demented. We can't say if you have a negative amyloid PET scan that you won't become negative. And we can't also necessarily predict about the loss of their confidentiality. If they had a positive amyloid PET scan, this is very far-fetched, but say their employer was aware that amyloid is a risk factor, amyloid deposition is a risk factor for symptomatic Alzheimer's. How would that affect their employability? Even with those caveats, 94% said, I want to know. I want to know my individual results. Matt Gobble from Political Science has looked at a national sample of individuals and asked them, again, hypothetically, about their potential interest in participating in a research study based upon us, our Knight ADRC, involving biomarkers. And he found that the key determinant was how well or how little people expressed that they trusted science. If they didn't trust science and scientists, the chances that they would sign up for the study were very low. Turns out our cohort, people who come into our Knight ADRC research cohorts, are more liberal and have greater confidence in science than the bulk of Americans. But even those individuals who said, I don't want to participate in research, 25% said, well, if you give me my results, I would then consider participation. So returning results may be an incentive. It has potential major problems. How will it influence our understanding of the natural history, if we're privy to the fact that people do or don't have their biomarker results? How would it affect their rate of participation? And how would it influence their performance on our measures? So we're going to pilot this and try to understand it better before we decide how to proceed. This Saturday, Jennifer Phillips and the Outreach Recruitment and Education Corps are launching 2 new initiatives. We're going to have our Memory and Aging Project participants eligible through our Knight ADRC website to ask the expert. We'll entertain, of all the questions submitted, we'll entertain one a month that myself or our other clinicians will try to answer. So this will be an opportunity for our participants to think that they have access to clinical expertise. We're not dealing with case histories. These are general questions. We're not going to do telemedicine, but we'll try to educate and inform people. And we're also setting up line on the web where people can say, listen, without a formal survey, they can come in and say that this is too much, I really didn't like this, I didn't like that person, I wasn't treated well, or I was treated great. Give them a chance for some feedback so that we can better understand areas in which we might improve. So I think I've mentioned this before. We surveyed a little while ago what of our many procedures that we ask of our participants do our participants find most challenging and frankly frightening and distasteful. And it's not lumbar puncture. It's the psychometric evaluation. They don't like to come in and find out that their memory isn't as good as they expected it to be. So, in part because of that, but also in part because of scientific reasons, Jason Hassenstab has been interested in alternatives to our standard psychometric battery, our standard paper and pencil test, which have a number of factors that may make the performances somewhat artificial. So one thing Jason would like to do is to increase the frequency of getting assessments rather than just once a year, to test in different environments, to reduce some variability, and to reduce our artificiality of coming to the Memory and Aging Project and getting tested. So he's developed a smartphone application that an individual who is a volunteer in our study will get a notification on their handheld device that it's time to take a test. You can do this several times over a period of days. The tests are quite brief, 60 seconds or less, and then you can average the performance over several of those days to get good reliability on these instruments. And Jason's working with a colleague, Martin Slawinski, who has expertise in this area. Here's the initial iteration of this smartphone device. You'll get a notification and some instructions that you will be looking at some pairs of objects on the upper part of the display, and then later you'll see whether those pairs are replicated in the lower part of the display, something like this. So you'll be asked to look at these three symbols, and then later which ones match. I'm pretty sure, Jason, that this one is the one. Is that right? Good. All right. My annual rant. Mr. and Mrs. Knight are quite clear that they would like our abbreviation not to be KADRC, but Knight ADRC. So please, in your presentations and publications, please pay attention. We're very interested in our participants, our volunteers, as joint members of our research efforts. We're not subjecting them to our research efforts. We want them to be partners with us, so please use the term participants. We use the term Alzheimer's disease regardless of its clinical status. So Alzheimer's disease refers to a brain disorder, asymptomatic or preclinical versus symptomatic. I think Alzheimer's disease is cleaner than Alzheimer's disease. This is an eponym, and we'd like to get away from eponomic descriptions of an illness, but I think Alzheimer's disease is cleaner. We no longer use the term dementia or the abbreviation for dementia of the Alzheimer type. The new terminology is Alzheimer's disease dementia. I've been using the term symptomatic Alzheimer's disease, indicating in a manuscript or a grant application that by symptomatic Alzheimer's disease I'm talking about both MCI due to Alzheimer's disease as well as AD dementia, and that has gone well. It takes away the judgment value of trying to determine if there's functional impairment or not. The symptoms, if caused by Alzheimer's disease, is symptomatic Alzheimer's disease. We've been using not non-demented. There are some individuals who say non-demented individuals include people with MCI. So when you say non-demented, you're talking about MCI plus cognitively normal people. Let's be specific. call them cognitively normal people. To abbreviate CDR sum of boxes, use the abbreviation CDR-SB, and be careful with your apostrophes. I see a lot of this, and please pay attention. So when you say people in their 60s, 70s, and 80s and use an apostrophe, that's improper grammar. Okay, our cohort, this must be the 5th time I've said how valuable it is, our cohort, but it certainly is not representative. The people I've already mentioned have a much more liberal political ideology than the most Americans. And of course, anybody who signs up for longitudinal biomarkers automatically is not representative of the general population. But as I mentioned earlier, it's not that they're squeaky clean. They have other illnesses common to older adults. The advantages is they're very thoroughly assessed and they're followed over time. And it's really the only longitudinal cohort of all people from age 18 to 100 that has both imaging and fluid biomarkers. If our participants don't contribute those biomarkers, then the value of our cohort is diminished. So I don't want to. Krista, why did you write us versus them? It sounds very provocative. Why would you do that? I just, again, for this group, want you to know that we do things differently than most all ADCs, and not many people understand that. So most ADCs bring people into their research cohort who have come from their clinic. That is, they've already been evaluated, have already been assessed, had testing, had imaging, and then they're deemed suitable for the ADRC. Then they're given the UDS, Uniform Data Set, not by a clinician as we do it, but by a research coordinator, graduate student, research assistant, and that research assistant generates the CDR. The neurologist comes along to do the neurologic exam, and then the person gets the UDS cognitive battery, and then they all get together and make a consensus evaluation of what that person represents, both in terms of whether there's dementia or there's symptomatic Alzheimer's disease or not, if there is, what the etiology is, and how it should be staged. So that's very different than we do it. And part of our difficulty over the years is trying to have other people who are accustomed to this way of doing it understand how we do it. So I just want you to be aware about our differences. The reason we set this up, by the way, we have a clinic, I've already mentioned the Memory Diagnostic Center, where we try to get all information and put it together and try to understand it. But for a research program, we think that the clinical assessment should be separate from the psychometric assessment, so that we don't get into circularity of saying people who perform poorly on memory tests tend to deteriorate in memory over time. Of course they do, because they were selected based upon their poor psychometric performance on memory measures. So the Knight ADRC supports pilot grants. In this most recent grant cycle, we awarded 23. Recipients come from many different departments, and they've been very successful. Taking the pilot data has resulted in 27 new grants, about $21 million of awards. Here are the current 2017-2018 pilot grants that began just this month, May of 2017. We're I think, very productive. We certainly do a great deal of data sharing, as I've already mentioned. So data, participant data, tissue from participants, and as I mentioned, actual participation in additional studies occurs a great deal. So we track all of this. It's important for us to show that our ADRC facilitates research by other investigators, both here and those external to Washington University. Hallmark of our program is its transdisciplinary nature. So 13 different departments at the School of Medicine, plus investigators from 4 schools on the Danforth campus: law, social work, engineering, and arts and sciences, particularly psychology, or now psychological sciences, chemistry, and political science. All of you should be very pleased about your contributions, and several of you, I hope we haven't missed too many, have been particularly singled out for honor and recognition in the past year. The Knight ADRC as a whole was named in March as the champion for the St. Louis chapter of the Alzheimer Association. We received the Champions Award. Bo Ansis was elected as a Fellow of the American Academy of Neurology. Ganesh Babulal received the Coppola Award. David Carr, the Distinguished Service Award from Driving Rehabilitation Specialist. John Cerrito, who received the Promising Investigator Award from MetLife. Liviu Murica has received the Innovation Award from the Academy of Science St. Louis. Kathy Rowe was named this year's Academic Women's Network Mentor Award, and Murtis Spencer was named by the St. Louis Celebrity Seniors with the Humanitarian Award. Let's give all of them a round of applause. So the Knight ADRC is supported by many partners, including the St. Louis chapter of the Alzheimer Association, our African American Advisory Board, which was inaugurated in 2000, and led by its founding director, Norman Seay, Links Incorporated, the St. Louis chapter, our Center for Aging, the Hope Center for Neurologic Disorders, the Barnes Jewish Hospital Foundation, and Washington University. I have to say that it's been terrific to work at Washington University in this transdisciplinary collaborative environment. Chancellor Wrighton is very aware of the Knight ADRC and all of you, as is Dean David Perlmutter. And my strong advice to all of my mentees has been pick a field for your research in which your department chair is also involved, because he'll or she will support it. And so Dave Holtzman's been a terrific advocate for the ADRC. We're very appreciative of our input from alumni in development, and Pam Morris and Zach Silvers, and our donors, and including the Knights and several others that have stepped up to the plate just this year. Now here's something that is we're all looking forward to. It's not directly related to the research program of the Knight ADRC, but to our faculty practice, the Memory Diagnostic Center, with the support of Joanne Knight, who also is a major donor to the St. Louis chapter of the Alzheimer Association. The St. Louis chapter has been able to hire Julie Whitley, a social worker, to serve as a care consultant in the Memory Diagnostic Center. That is, our Memory Diagnostic Center patients now have a dedicated person if there are questions that the patients and the families have about anything related to Alzheimer's, but very practical things. My mother comes to you from Hopkinsville, Kentucky. You see her. My brother's caring for her there, but now her dementia has progressed to a point where he can't handle her. I'd like her to come to St. Louis where I can watch over her, but I don't know what long-term care facility she should be in. Should she be in a nursing home or not? And Julie now is a person we can turn those sorts of questions, which are very common, and she will help us provide better service to our patients and their families. I've mentioned our African American Advisory Board. They've been remarkable. They're very dedicated, and they're very informative. It's been a tremendous learning experience for me to try to reach our goals of being a welcoming program for people throughout all walks of life and all groups of individuals, as well as very diverse. And one of the flagship events of the African American Advisory Board, in conjunction with the Knight ADRC, is the Norman R. Seay Lectureship. And the next one will be October 17th, and it'll be Monique Williams, who now is the medical director of a hospice program here in St. Louis, but is a former Knight ADRC faculty member and clinician. Of course, we provide educational opportunities to many individuals and have done this for many years, and kudos to Andre Denny and Jennifer Phillips, who spend great hours trying to go through all of the requirements to allow these training experiences to occur. We have 3 students this summer who come from Tulane University, St. Louis College of Pharmacy, and the University of Missouri in Kansas City. And we have, of course, continuing visiting scholars. Now, this is information that may not last. But right now, if you have had this shows the wisdom a year ago trying to get people to submit applications to the NIA was challenging because, 1, of the uncertainty of the funding environment, and 2, because it's uncertain, the NIA had very tight pay lines. They didn't want to commit to funding grants if Congress wouldn't appropriate the funds. Well, now people who submitted recently have very good news, at least as of May, until the next crisis in Congress in September or October. The funding has been bolstered dramatically. $400 million targeted for Alzheimer's disease research alone. And you can see the pay lines now. If you have an AD-related grant, every investigator has at least a 25% chance of being funded. And if you're an early stage investigator, almost a third of people will be funded. So this is terrific. But we can't count on this. So it always is good, even when the funding environment seems dire, to submit, at least have your grant in the queue. And if we do get this boost that is sorely needed, then you're in good position. These are the grants that have been awarded. Yi Su and Yang Wang have both been awarded a grant from the BrightFocus Foundation. We have several that are in the line for review, including the Andrei Vlasenko, Mark Rako competing revision to the adult children study for their metabolic imaging. And several R01s are waiting to see if they will be awarded under this new funding situation, as Suzanne Schindler will be with her her mentored career development award. So we've been fortunate. As I've said, we've first and foremost have always had our grants renewed, not without effort, not without concern, but we've always had that renewed. And if you look at all the grants that come to Washington University, not just the Knight ADRC and its programs, but all the grants, we're somewhere around $67 million for this year alone. And if you compare us to geographically related programs, we do extremely well. You can see that we stack up very well to major universities, including the University of Illinois and University of Kansas and University of Missouri. So we've been fortunate. So my final slide is to really thank you, because not only our participants, but all of you are extremely talented, enjoyable, productive faculty and staff. You make up the Knight ADRC. So I thank you all.